Narasimha. I'm fellowship in neonatology. I'm working under Dr. Karthik sir. So if you take the oxygen, so
On
oxygen is sorry.
Dr. Should I change the slide?
Yes. Yeah, oxygen is one of the most critical component of life. So that's the reason why if we use oxygen judiciously, because the lesser oxygen will cause some side effects, and the more the oxygen will also cause some side effects. So this is one of the most critical component of life where the underuse or overuse will cause a lot of issues. Although oxygen is used most widely therapeutic agent in neonatal care, but optimal gas oxygen management remains uncertain. So that's the reason why we're discussing about in the coming slide, I'm discussing about the oxygen levels and the FiO2 levels and the saturation levels as well. Now, can I go next slide? So first I go by definition. So what is FiO2? So we keep on increasing FiO2 from 21 to 25, 30, 40 based on the child saturation. First we need to know what is FiO2, the fraction of inspired oxygen in the concentration of oxygen in the gaseous mixture. So when there's a gaseous mixture, in that, what is the fraction of oxygen is there? So in the room air, generally 21% is the fraction of oxygen that is present in the gaseous mixture. So it is like how much amount of oxygen is there at the in the gaseous mixture. That's called fraction of inspired oxygen, FiO2. That's a basic thing. Then, so to understand FiO2, it is very important to understand certain terminologies. If you know certain terminologies, then you can able to know the importance of FiO2. So first thing is hypoxia. It defined as decreased in the partial pressure of oxygen in the blood. Whenever the partial pressure of oxygen in the blood, it's called as hypoxia. After that, we need to know the partial pressure of oxygen of arterial as measured by ABG gas sample. Every time we used to do ABG gas sample, then based on that, sometimes we used to increase FiO2 because the partial pressure of oxygen in artery is very important to decide the FiO2 as well. Then another thing is partial pressure of oxygen in the alveoli is a calculated value. So these things are most important, and they will determine the FiO2 levels in the baby so that the baby will maintain good saturations and good oxygen levels. So oxygen saturation, it is a measure. So I told you FiO2, it depends on the concentration of the fraction of the oxygen present in the gaseous mixture. Now the saturation comes like it is like it depends on the hemoglobin levels, because the hemoglobin is the where the oxygen will comes and bind to the hemoglobin. So there are four, as everyone knows that there are four globular proteins. So whatever the oxygen we provided through FiO2, it will go and attach to the hemoglobin, and that will lead to a saturation point. So that's the reason why we will check the saturation. So saturation is it depends upon hemoglobin, and FiO2 depends upon the percentage of oxygen present in the gaseous mixture. Then next slide, please. So, if you take oxygen, oxygen is a potential vasodilator involved in the transition at birth to the breathing. So, it is a potential vasodilator during the transition phase from the fetus to the neonatal phase of immediate after delivery. It is helpful as a potent vasodilator. And supplement of oxygen is administered to reverse the hypoxia. I told you the hypoxia meaning it's like it is a decreased in the oxygen levels. It's called hypoxia, where the supplement of oxygen will be helping us to reverse or prevent the hypoxia. However, I told in the before as well, oxygen cannot be used more, or it can be underused or overused, will be having a lot of issues. In that thing is formation of reactive oxygen species. This is the most important thing, because if you use overly, it can cause this ROS and all. So currently the resuscitation guidelines which says recommended using room air for term infants in need of support. So any term infant, if they need a support in the labor room, so first we start with the room air FiO2, and with titration to achieve oxygen saturation level similar to an uncompromised term infant. So there are two infants are there. One is a term infant, uncompromised, everything is fine, child is vigorous, had a good cry, tone is good, everything is fine. Then another baby is having a compromised set. Whether it is compromised or uncompromised set, in the term baby always starts with an FiO2 21. That you can know in the further slide. So hemoglobin is a traditional considered as oxygen carrier in the body, and however it plays a sophisticated role in oxygen regulation as well. So the affinity of the hemoglobin for oxygen varies according to the partial level of oxygen, the partial pressure of oxygen in the blood, and the level of hemoglobin saturation. If you go by, as everyone knows that we are studying from the first year of medicine, it says that what is it called? The curve, like oxygen dissociation curve. It mainly depends upon the temperature the pH and the 2,3 diphosphoglycerate and carbon monoxide levels. It is there. So I think the next slide will be helpful for us most. See, this is the curve. We know that thing. So when the curve is shifting towards left or shifting towards right, you know the what are the parameters to be checked down. So first thing is the temperature. That's the reason why we have a quality program going in our Manipal hospital, from the transition, like from the delivery room to the transition room, where we always manage the temperature through a incubator, and that quality project is going on in our unit as well. So the temperature plays a very important role, and the pH of the baby plays a very important role, and it also depends upon the 2-phosphodiglycerates and carbon monoxide that is forming due to hypoxia. Then we can go ahead and change. So coming to the point, right? The main topic for me is today is oxygen use in labor room and FiO2 levels and saturation. So any term or near-term infants in need of IPV, the positive pressure ventilation at the delivery room, should start with an FiO2 of 21 or 0.21%. Between the ages of 28 to 30 weeks of gestation, the initial FiO2 will be 0.21 to 0.3 generally recommended. So if you are going into the delivery room, you should always ask, it's a term baby or a near-term baby. And if it's needing a support of a positive pressure ventilation, we need to start with FiO2 21. If you are going for delivery like a preterm, like 28 to 31 weeker, and initial will be from 0.21 to 0.3 or 21 to 30 FiO2. For immature infants, the higher FiO2 than 0.3 may be needed. This point I'm going to explain in the last slides as well, because how the higher FiO2 we have an outcome in the baby as well. Although the optimal levels are not well defined for all age groups, it is recommended to adjust FiO2 as per the condition. So according to the oxygen saturation, this point I want everyone to listen, because according to the oxygen saturation and heart rate response, for immature infants, the combination of prolonged bradycardia and SpO2 not reaching 80% within the 5 minutes of life is associated with a substantial increase in the risk of death. So it is always important to know us when to start oxygen, because when to start giving that FiO2 or pressure, because any infant, immature infants having a prolonged bradycardia and FiO2 not reaching 80% within 5 minutes of life, the chance of mortality is increasing in the babies. So for images beyond the delivery room, the SpO2 saturation between 91 to 95 is recommended. So immature infants beyond the delivery room, SpO2 should be managed between 91 to 95. And any immature infant having a compromised thing, you should go. Like I told now, prolonged bradycardia and oxygen is not saturation is not maintaining, not reaching 80, it's a dangerous sign for all of us. Then the next slide says, next slide. In premature infants, targeting a high saturation range, like example, like 91 to 95, may be safer than a lower range. But more evidence is needed on it. The studies are going on. I want to present one of a study later. It says that higher oxygen saturation, some 90 to 95, may be safer than targeting a lower oxygen, range as well. In combined analysis, low oxygen saturation levels increased mortality, suggests that higher target may be safer. There are two things here. One is mortality and morbidity. And just to make you understand, I'm just quoting like this. If a higher saturation, higher FiO2s or higher saturations are used, the chance of mortality will goes down, but the chance of morbidity is high because of retintive ROP and other things as well. But if you take a low oxygen saturation points, the chance of mortality goes high. I will be presenting one study. It says that the risk between is 33.3 when you use a low saturation, low oxygen saturation, but it comes down to 26% when you use a high saturation points in a premature infants. The next slide. So what are the delivery room guidelines for oxygen use? It's like every neonate requiring resuscitation. Please make my word requiring resuscitation. The first step is to clear the airway. After the airway, assessment of oxygen is very much important for the child, because I told resuscitation because sometimes they have an uncompromised neonate, like the baby cries after birth, everything is fine, the tone is good, child does well, and everything is well. Even in an uncompromised neonate, to achieve an extrauterine saturation, while approximately takes 10 minutes after birth, and skin color may suggest some cyanosis as well. Even in uncompromised infants, it takes 10 minutes to get a extra uterine saturation. Then what is the use of a pulse oximeter? So pulse oximeters are recommended when resuscitation may be required, administering positive pressure ventilation lasting for more than few minutes or few breaths, and cyanosis persists. Administration of supplemental oxygen is needed, because I have worked in a couple of private setups as well before. So I see immediately baby was born. Instead of focusing on the temperature or as a cleaning or as a airway assessment, people are more focusing on the pulse oximeter. So my point is, pulse oximeter is recommended when resuscitation is needed, and pulse oximeter is recommended when you need a positive pressure ventilation for lasting for few breaths, if a cyanosis persists, and if you're administering oxygen. Pulse oximeter is in need of the hour. In an uncompromised child, you can, like, the pulse oximeter can be used because it takes 10 minutes time to reach the extrauterine saturation. So always you focus on the temperature of the baby, warmth of the, the overall condition of the baby.
Dr. Narasimha, please finish in 2-3 minutes. Okay.
Yes, sir. Then can I go for next slide? So normal oxygen saturation in healthy newborns is 93 or greater, with a gradual increase in the levels over the first 10 minutes is after required. Can you go next slide, because I want to. So these are the preductal saturation points. Everyone knows this. Our NRP has this twin. So by 10 minutes of the time zone, the saturation should be 85 to 95. The next slide. The same thing. You can go next slide, please. So this is the thing I want to present. The boost trail and the previous. Yeah, this is the thing. This is called a boost trail. It's called boost, means benefits of oxygen saturation targeting, and one more trail is called COT trail, which is called Canadian Oxygen Trail, and one is called support trail. All these trails, boost trail, support trail, and COT trail, says that they have a standardized oxygen saturation levels. So they have a higher level and a lower level. Higher level and lower. It says that if you take the relative risk and if you take the risk of the baby, the higher oxygen levels will have a greater impact in decreasing the mortality of the baby. Decreasing the mortality of the baby, but in lower, there is a chance of increasing the mortality of the baby. If a higher levels are maintained, there's a chance for ROP is much higher when you manage the child with a lower. This slide I'm going to change. I'll present group as well. So boost trail, support trail, Canadian trail all says that higher levels will have a greater impact in decreasing the mortality and decrease the mortality. That's it. The next slide, please. So this is one more trial, a systemic review on individual participant data network analysis. It also says on FiO2 on reducing the mortality. Can you go next slide, please? Yeah, they have found that higher compared to lower initial FiO2 for a delivery room. Resuscitation of a premature infant born at 32 weeks of age. As per this thing, higher FiO2 may be associated with reduced mortality in preterm infants born less than 32 weeks gestation. So they're and compared to the lower FiO2. So higher initial FiO2 is possibly associated with the reduced mortality compared with the intermediate initial FiO2 or else a very low FiO2. Next. So what we know? Until now we know use of oxygen for 21% is effective and safe for neonatal resuscitation, and use of 100% oxygen will lead to reactive oxygen species, and that may lead to in the days to go, it can land up in ROP, CLD, and necrotizing enterocolitis. So lower oxygen saturation targets 85 to 89 increase mortality, and higher oxygen target ranges increases the ROP. That's what we know after all this talk. The next slide, please. Then what need to be studied? Effect of wider oxygen saturation target, like from 87 to 94 or 85 to 93 on death and death. This is the thing where we want to study more, and ability to adhere oxygen saturation target groups also going to study more. Then last point, then I'm going to conclude with this thing. The next, so what can we do today to maintain the oxygen levels and FiO2 level saturations? Use alarm settings on oximeters to prevent hypoxia and avoid hyperoxia. Delayed cord clamping is one way you can help us to get more hemoglobin for the baby, And blending of oxygen is also one of the important thing in the delivery room or in an NICU, which will help us to get a better outcome than without the blenders. Because I worked in a centers without blenders, I have seen a lot of children, a lot of babies standing up in other things. But with the blending of oxygen, it has been a game changer for us. Next. So thank you everyone, and we should thank God for every breath we breathe. And we are all the neonatologists. We give breath to the baby so that they breathe longer and healthier. Thank you.
Thank you, Dr. Narasimha. Very good presentation, and you covered very important points, including the final slide is key that you manage your target oxygen. Don't turn off the upper limit of the saturation even in term babies, even in babies with PPH, and we don't want to cross 97%. So 91 to 99 is the target range in the NICU. In the labor room, we will discuss a little more. I have a couple of slides on what you discussed on the new study, which Dr. Karthik mentioned last time as well. So it's hot off the press, and we have some critique for that. Dr. Priyanka, you had your hand up. Do you want to speak? Dr. Priyanka, please unmute yourself.
Am I audible now, sir?
Yeah, please go ahead.
Sir, in the settings which we attend the deliveries, they don't have blenders. So it's it's easy to resuscitate the term newborns, but it becomes very difficult to resuscitate preterm newborn because as usual we don't have blender there, and we can't force them to buy blenders also.
Do you
So,
have pulse
is there any
oximeter?
way that we can help these babies without blenders?
Do you have a pulse
We
oximeter?
can set the flow accordingly and then give the desired FiO2. Is there any
No,
way we can help these babies
do you
without
have pulse
using blenders?
oximeter? I'm asking you. Do you have a pulse oximeter? Can you hear me?
Yes, sir. Yes, sir.
Do you have a pulse oximeter?
Yes, sir.
Okay, I mean, we do have low-cost blenders now, Venturi-based ones, and you can look at the market availability. What you need to stress to your management is the medico-legal risk of not using a blender, because there is an epidemic of ROP and the most litigation risk, which awards are rewarded. So you bring them 2 or 3 cutouts of these ROP-based, it's like lakhs of rupees that are awarded, I think 1.2 crores or something. So take these cuttings and tell them if you don't start with a blender, even in a near term, maybe you can get severe ROP. That's why the NNF has expanded the ROP guidelines to cover. So please make a point to tell them how it works. I mean, basically, if you tell them there will be a big financial hit, they will listen to you. You have to threaten them in these ways. Make sure they understand the implications, and Venturi-based cheaper ones are available. You don't need the exact control. Of course, you have ranges there. You have 40%, 60% like that. So even if you titrate to some extent, it's better. But till you get that, you can start with, in the less than 32 weeks, you can start with 100% and use the saturation, and then trim down quickly and move the baby quickly to the NICU, where probably you have a CPAP machine with blender. Or you can take the CPAP machine with blender to the NICU. Again, during our recent workshop, I mean, Dr. Karthik, you want to add? We had this machine which is Venturi-driven blender as well with the CPAP machine, and it's part of the transport incubator. You can use those to take to the NICU as well, to the labor room. Dr. Karthik, you want to add?
No, now, in fact, new indigenous devices are available. They are very inexpensive now, Priyanka. Even for 25, 30,000, good blenders are available. I don't think in today's era, as Dr. Sridhar said, we should avoid the blender. We have to insist on having a blender. But having a good pulse oximeter is also equally good. So I was just referring to pulse oximeters in the labor room, which normally we would use the ordinary ones, but a good investment in a signal extraction technology pulse oximeter like the Massimo meter will be better, because especially preterms when they are hypoperfused and there's a lot of motion artifacts, that can take care of those and give you a good signal, and you get decent pulse oximetry readings in the labor room soon as the baby is born. So this is something I just wanted to emphasize. Yes.
Yeah, the Venturi works like what you said. It trains in air. You start with 100% oxygen, and then you open it to different levels where it, because of the velocity of the flow, it trains in air. You asked about charts to adjust the cutoff. I mean, Dr. Netra mentioned Dawson's charts. Maybe you could share it in the group as well.